All right, I always like to start with a prayer. Dear Father in heaven, pray you can be with us as we look at ways of recognizing Alzheimer's and then being able to utilize things you've given us to help prevent it and reverse it. I ask your presence in Jesus' name. Amen. Okay. Diagnosing Alzheimer's. You've gotten some information on diagnosing it. I want to give you some feeling as to what it looks like when it's coming on. So what is Alzheimer's? Well, there's a normal nerve. Branches from the nerve are what signals the next nerve, and that's what's important for being able to think and process information. For the signal to get from one nerve to the next, it has to cross a synapse. It's a gap. And in Alzheimer's, there's a plaque in the gap which blocks the transmission. That's the current thought, and that's what starts degenerating or slowing down the thinking process. So why is the amyloid formed in the first place? It's actually your body's defense against toxins, infections, decrease in nutrients. It's a defense mechanism, and so we're not going to talk about that here, but you want to really get to the cause of the problem rather than just getting rid of the plaque. It's kind of like in pneumonia. Pneumonia, your white count is very high because your body is releasing white cells to fight the infection. So the treatment is not to get rid of the white cells. Okay, if you do chemotherapy to get rid of the white cells, you make the problem worse. And that's why they found that just getting rid of the amyloid plaque isn't the real solution. You need to get rid of what's causing the body to form the plaque in the first place. But that's a different topic. We want to look at what Alzheimer's looks like so you can be alerted to start taking some of the measures that Dr. Youngberg was talking about here. So what does it look like symptom-wise? Well, a lot of times short-term memory can go first. Had a story of a chemist. He was having dementia. He had a stroke. We'd admitted him to the hospital, but he also had dementia after that. He was a very good chemist in his time. He's now retired. He was looking for things to do. And so he would volunteer at the hospital. And he'd get a job at Lowe's just to get something to do. So I went to Lowe's one day, and I talked to him, and we had a little conversation. And then he said, well, now, what are you looking for? I said, well, I need some mothballs. He says, 1,4-dichlorobenzene, right this way. Okay. Long-term memory for him was still intact. Short-term memory was a problem. So what's it like to descend into Alzheimer's? Dr. Dalip Bredesen is the one that's really been doing the work, spearheading the work on getting it to reverse. And what he describes in his book, he says, for a long time, we didn't know what going into Alzheimer's looked like from a patient's perspective, because once they were there, they had no idea what it was like to get there. But since he's been getting people coming out of Alzheimer's, now we've got a record of their description of what it was like going into Alzheimer's. This was his first book. We want to look at this book was basically presenting the scientific explanation as to give you confidence that what he's doing has some scientific background and basis. It was a little bit challenging to come up with the protocol to actually do the program. I came up with, in other words, you have to just go different places to find out what to do. You've got a handout there where I've taken the lab tests and shown you what's abnormal, and when you find a lab test that's abnormal, refers you to a page in his book where he describes what to do about it, what the problem is, and how to address it. His second book, The End of Alzheimer's Program, is a little more how to do it, step by step, what to do if you've got it, steps to take to try to pull out of it. So from his first book, he actually describes what it's like to go in. I just want to give you a synopsis because diagnosing it, what we're looking at today, how do you diagnose it? You want to get the symptoms first because that's your first clue. This is from Dr. Bredesen's, one of his first patients, Kristen, described in Bredesen's book, The End of Alzheimer's. She was the first patient treated with Bredesen's protocol. She was suicidal. Years before, she had watched in despair as her mother, mind slipped away, forcing her to enter a nursing home after she could no longer recognize family members, let alone care for herself. Kristen had suffered along with her mother, who at age 62 had begun an 18-year decline into Alzheimer's. At the end, Kristen suffered alone because her mother was no more sentient. She couldn't understand or see or understand what was going on. When Kristen was 65, she began to experience her own cognitive problems. She got lost when driving on the freeway, unable to remember where to get off and get on, even in familiar routes. She could no longer analyze data accurately, critical to her job. She couldn't organize and prepare reports in a timely fashion. Unable to remember numbers, she had to write down even 4 digits, not to mention phone numbers. She had trouble remembering what she read. By the time she got to the bottom of the page, she had to reread what she read at the top of the page. She couldn't remember it. Reluctantly, Kristen prepared for her resignation. She began to make mistakes more and more frequently, often calling her pets by the wrong names, having to search to find light switches in her own house, even though she'd flipped them on and off for years. Like many people, Kristen tried to ignore the symptoms, but they got worse. And this is another thing. Patients may deny it or not recognize it. Many times, close family members are the ones that start picking up the problems. If you have a family member that is starting to experience these things, it'd be good to have a talk with them and see if you can actually go to someone that can help walk you through this. But you're going to need to go with them because they're going to need an informant, someone who can give an accurate history because the patient themselves usually can't. So she wrote 2 years after unremitting cognitive decline, she consulted her physician, who told her she was becoming demented just as her mother had, but there was nothing he could do for her. He wrote memory problems on her chart, and because of that, she could not obtain long-term health care insurance for long-term care. She underwent retinal scanning, which we're going to talk about a little bit later. It's not currently used, it's not currently authenticated, so to speak, but it is promising in the future. Anyway, she went under retinal scanning where they could see the amyloid plaques in the back of her retina, which revealed Alzheimer's-associated amyloid. Like many people, Kristen tried to ignore these problems, but they got worse and worse. She called her best friend Barbara, explaining, "I watched my mother go into memory decline, and she slipped away, and there's no way I'm going to allow that to happen to me." She was going to commit suicide. So Barbara was horrified at Kristen's saga, but unlike when other friends had fallen victim to dementia, this time Barbara had an idea. She told Kristen about the new research she'd heard about, suggested that rather than ending her life, that she go travel several thousand miles to the Buck Institute for the Research of Aging just north of San Francisco. And in 2012, she met Dr. Bredesen. They talked for hours. He could offer her no guarantee, no example of any patient who had used the protocol, nothing more than diagrams, theories, and some data on transgenic mice. In reality, Barbara had been a little bit premature and sending her to the Buck Institute. And to make matters worse, the protocol that he had developed had just been turned down for its first proposed clinical trial. The review board felt it was too complicated and pointed out that trials are meant to test only a single drug intervention, not an entire program. You got to realize, to do a clinical trial costs money. And if you're going to do a trial, you've got to have a return on your investment. A new drug has the potential of offering a return on your investment. A program that deals with multiple aspects of your lifestyle, where's the return? that's very difficult to get a trial in that, to test for that. So all he could do was go over various parts of the protocol, recommend that she take these to her physician at home and ask if he could work with her. She did that. She became the first person to do what they now call the RECODE protocol. 3 months later, Kristen called Dr. Bredesen at home on a Saturday to say that she could not believe the changes in her mental abilities. She was able to work full-time again, to drive without getting lost, to remember phone numbers without difficulty. She was able to, she said she felt better than she had for years. And when he put the phone down, Bredesen recorded in his book, he said, what rushed into his mind is decades of research, countless hours at the whiteboard with lab members and colleagues, the arguments with himself about each detail of the theory and the treatment approach. And all of this was not in vain. It had pointed them in the right direction. And so you're going to want to know about the RECODE program. However, the program is labor intensive and it can be expensive. Lab tests can be expensive. The first protocols we did, we used LabCorp for a lot of the tests. And we have a professional co-op. Physicians got together and negotiated with LabCorp for lower prices. So LabCorp said, fine, we will give you those prices, but we will charge your bank account directly. So LabCorp is guaranteed that they get paid. The doctor then charges the patient, and he can do a markup if he wants. But the LabCorp cost, the discounted cost, like $1,500 just for the battery of tests that were required to see what was causing the amyloid formation in the brain, because different assaults had to be checked for. So you want to be sure that they've got Alzheimer's. They could have dementia with Lewy bodies. They could have frontotemporal dementia. They could have multi-infarct strokes. We had, and this program isn't designed to address those. We had a lady who came to us to work, help us. We were going to help her work through this RECODE protocol. And I said, you need an MRI first because we need to make sure we're not dealing with some other form of dementia. Well, she didn't do it. She came, we went through our program, we started on the RECODE program, got the tests and everything, started on the program. Then a couple of months later, she had a major decline in her mental abilities, status. They took her to the ER, MRI, showed she was having strokes, multi-infarct dementia. And that's something, so again, she took a lot of time and effort to do a program, and it wasn't addressing her real issue. So you want to get a firm diagnosis of Alzheimer's before you start. Well, symptoms are the first clue that someone's got Alzheimer's. Problem is Alzheimer's progresses for about 15, 20 years before symptoms develop and diagnosis is made. To make matters worse, the initial symptoms may be dismissed or ignored. So what do we look for in the history? Then we're going to look at an example from Bredesen's book here. It says, it usually occurs after age 60. Incidence doubles every 5 years after the age of 65. Early onset occurs in only about 5% of Alzheimer's dementia patients. That would be onset before age 65 in terms of symptoms. Usually presents atypically with language, visual, and mood behavioral changes, predominantly memory changes. The autosomal dominant inheritance accounts for less than 1% of Alzheimer's dementia. It occurs in the 40s or earlier. So there's very few get it in the 40s or earlier. Down syndrome patients, they have a trisomy 21. And with that, in other words, they have 3 genes instead of 2 number 21 gene. And so they have an extra gene which generates more amyloid plaque and puts you at higher risk. And they typically get Alzheimer's dementia. Memory impairment is the most common initial symptom, usually can be elicited even if not the primary complaint. Cognitive impairment may appear with or after the memory impairment. Declarative episodic memory, that is the memory of events of a particular time and place in the past, are usually profoundly affected. The hippocampus helps you remember things and tie a date and a time and a situation to it. And it's the hippocampus that tends to be shrunk and not functioning. And that's why this episodic memory, in other words, an episode in the past, date and time remembered, that is severely affected. Recent memory of recent material that has departed from the conscience must be recalled is one of the most prominent defects. The MoCA test is a good way to do this. You saw a picture of it previous talk, the MoCA test. It asks you to give the patient 5 words and say, I'm going to ask you what these 5 words are in about 10 minutes. Then you ask other questions so that the 5 words are no longer in the current consciousness. And then in 10 minutes, you ask him, what were those 5 words? And I always get a little concerned when I have to go back and see what were those 5 words. But at any rate, that's one of the things that does go frequently. Vocabulary and concept memory deficits progress slowly and appear somewhat later. Procedural and motor memory are spared till much later. Immediate recall, that's mental rehearsal of a phone number, is spared initially. Long-term memory years ago is spared initially. Executive function and judgment, problem solving is variably affected. An informant may report the patient is less organized, less motivated, can't multitask, and later cannot complete tasks. They may have reduced insights into these deficits. Patients may be in denial, and the informant input is necessary. You got to have someone there sharing what the deficits are. Early on, there can be behavioral changes. These are usually apathy, social disengagement, irritability. They can have fragmented sleep, and seizures can occur. Later, behavioral changes occur. These can be agitation, aggression, wandering, psychosis. These are much later symptoms, and they usually would happen after you've already got a diagnosis of Alzheimer's. That's not what you would look for initially. Apraxia, that's difficulty doing learned tasks. That's a much later problem. You can test for that. How would you use a comb? And they would, show you that it would do this, and they wouldn't be able to do that. So that's a lot. The symptoms are listed there basically in your notes, more for a reference, so that you can go back over them. But let's look at a real example. Bredesen gives an example of what it was like going down into Alzheimer's. And this is Eleanor. And if you have your handout with questions on it, these are some of the questions you can ask a patient or someone you're worried about. She's going to tell you what it's like. So the first thing that she noted was facial blindness. She had difficulty recognizing faces. That's called prosopagnosia. On the handout, you can just ask simply, do you have difficulty recognizing faces? Or ask the informant if that's a problem. Decreased mental clarity later in the day. She said, helping my kids with homework felt mentally exhausting. It was similar to the feeling I would get when I was in college and grad student after studying intensively, taking long exams, except that it would happen at 3 p.m. without my having mentally exerted myself at all. In addition, reading, especially later in the day, became increasingly difficult, and I often had trouble remembering what I read, sometimes even from one page to the next. I would fall silent in group conversations, especially when they involved more complicated, controversial subjects. I often felt I didn't have anything to add, that ideas just weren't there. And remember, in a conversation, you're having to remember what was said before so you can respond to it later. And of course, that's very difficult with Alzheimer's. Do you have mental fatigue as the day wears on? That's a question you can ask. It'd be question 2 on your question sheets there. Decreased interest in reading, an inability to follow or engage in complex conversations, an inability to follow movies or complicated plots. She says, conversations became tiresome for me, and I didn't know why. Because again, with a conversation, you've got to remember what you've been talking about so you can add to it, and that memory wasn't there. She had decreasing ability to recall what she read or heard. It felt exhausting, she said, to try to remember things, whether it was what to get at the supermarket or what kind of sushi my kids wanted to order. Required course reading, she said, seemed very dense, and I had no recall. I also had difficulty remembering other things I'd read, like novels or magazines. Reading, which I used to crave, she said, was no longer a pleasure. To follow the conversation, of course, you need to remember what was just said or heard. To follow a plot, you need to remember what you read in the book. So here are some questions to ask. You can say, do you have trouble remembering what you've just read, especially later in the day? Do you have difficulty following and entering into group conversations? Do you ask the same question over and over? The reason they ask that is because they can't remember that you've already asked that and answered the question. They can't remember even short term. Do you have trouble following a complicated movie or story plot? Decreasing vocabulary. She stopped using more sophisticated words. I might say aggressive, but had stopped using pugnacious or truculent. I've never used those words, okay? Anyway, she had a very good vocabulary, and it was getting limited. I would say, she goes on, she says, I would say someone was thinking about something over and over instead of saying that he was perseverating on something. I would say, yeah, she'd find a different word. Now, again, yeah, I don't use those words either. I would say someone was very social, but I wouldn't say gregarious. Along these lines, I would also do word searches when speaking, where I might pause looking for a word. This is one of the easiest first things to notice. The patient will be talking, and then they'll pause, and they'll try to think of the word, bring up the word to say. It's called word searching. And people can function fairly well, and you might not think there's anything wrong with them, but if they've got this word searching problem, that's one of the first tip-offs that they may have a real problem. And it's easy to pick up. In fact, we had one lady, she had severe word searching problem when I saw her, and as she started, her main problem was insulin resistance, which is a pre-diabetic issue. And when she went on the vegan oil-free diet, her weight dropped, and I talked to her again. She was talking, and there was no word searching. I mean, it was just bang, 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 and it was just like night and day change. And that was something very easy to pick up on. She reports, she said, I usually come up with a decent word or find a roundabout way to say something. For example, I would say someone went about something following step by step, like they should, because I couldn't access the word systematic to say systematic approach. Then she would start mixing up words. It was not unusual for me to mix up my kids' names from time to time. But what started to happen shortly before I made my appointment with the clinic was that I would use words that were completely wrong. For example, she says, I was taking my kids to school. I called to the toll booth operator loudly and confidently, conference call, instead of carpool, to get my carpool discount. Another occasion, I called my dog in the yard yelling chili, which is what I was making for dinner, instead of Juno, which is her name. She would mix up words. So a question you can ask, do you sometimes mix up words, using words that are completely wrong? She had decreasing processing speed. Things would get figured out more slowly. Now, this isn't a problem if you've got a lot of time to process something, but if you're driving a car or doing something that needs quick processing, that becomes very difficult and stressful because the patient starts to know that they're having trouble processing. She said her thoughts were coming more slowly, feeling fuzzy during work meetings in particular. And when she typed more slowly, said it was tough for the signals to get from her brain to her fingers. She had increased anxiety about driving. The many things drivers need to see and process, from position and motion of other vehicles to the meaning of traffic signals, caused Eleanor extreme stress, and she could barely operate a car anymore. So, what you can ask a patient, you can say, this is number 7 on your list there, does your brain feel fuzzy when trying to solve a problem or respond to demanding situation, like a conversation or a meeting? Now you can say, do tasks such as typing take longer to do? And does driving cause increased stress? Any task requiring quick thinking will cause stress. She had trouble finding her way. It was hard knowing which exit to get on and get off on. So you can ask him, do you get lost in familiar areas either when you're walking or when you're driving? She had difficulty remembering her to-do list for appointments, often feeling overwhelmed by what needed to get done. Eleanor had started missing appointments. She was becoming very anxious and stressed about not being able to keep track of everything going on in her life, she said. She said she used Google Calendar and had reminders everywhere, but was still forgetting things. She said, when I was younger, I used to be so confident in my memory. I never missed appointments and memorized phone numbers the first time I dialed them. Very sharp. So, you can ask them, do you have trouble remembering a schedule? Do you miss appointments? Do you feel overwhelmed with all you need to do in a day? Sleep disruption is also common in Alzheimer's. She says, I would awaken easily, and when I did, I would get a great difficulty falling back to sleep. Sometimes it would take hours. I would also awaken many times during the night. So, simply ask him, do you awaken during the night and have trouble falling back to sleep? That's a general question. Other things, particularly depression, can also cause this problem, so you need to rule that out. She was no longer getting a mental boost from caffeine. I don't recommend using caffeine, but this was one of her initial symptoms. And she had trouble speaking of foreign languages, including Chinese, Russian, that she had once been very proficient in. There are other things that you can ask. Are your symptoms interfering with your work or usual activities? Number 12 there says, do you have trouble planning a task and carrying it out? Can you balance a checkbook? Balancing a checkbook is a very good question because that's what a lot of people will be doing. And if they can't do that anymore, that's another tip-off that there's been a decline. You can ask the informant, have you noted significant changes in personality or behavior? And quite honestly, you'll probably get more information from the informant than you will from the patient themselves. How did she feel? Well, she wants to articulate. She says, I want to articulate what it felt like to be in a fog of early cognitive decline. Something I feel I have a special perspective on because I climbed out of it. She further says, I came up with an analogy of the feeling you get when you're wearing headphones and trying to talk to someone next to you. It sounds muffled. You feel more distant from others. Similarly, before I reversed, it felt like I had a film of gauze over my brain, and that kept me from really connecting with others and being able to easily engage in normal conversation back and forth. It was sometimes an enormous effort to formulate my response, such as in work meetings, and then to convey it without forgetting what I wanted to say. It was as if that gauze were a barrier I had to punch through to get the thought out. Conversations about more sophisticated topics have become far from the effortless activity that it had been when I was younger. What happened to Eleanor? What we're going to see shortly. So after you get a history and you say, yeah, there are some significant symptoms here, you can do the MoCA test. This is a 10-minute test. You saw the picture of it earlier. Very simple, and I'm always surprised. You can actually be talking with a person and they seem pretty normal, but when they do the MoCA test, they may have problems, difficulty doing some of the simpler tasks. And I'm always surprised that, wow, they can't do this. This really is significant. This can help also pull a patient out of denial. The informant may be saying, yeah, they've got memory problems. Then the informant says, nah, it's not a big deal. I can handle it. It's not a problem. But when they go the MoCA test and you get a score, you can say, yeah, you do have a significant problem here. Up to Date, which is one of the premier medical references, the authors of the Alzheimer dementia diagnostic topic report that the Montreal Cognitive Assessment is our preferred brief assessment tool because it has better sensitivity for executive and language dysfunction compared with other brief tests such as the Mini Mental State Exam, the MMSE. And you'll want to get the test. By the way, there is a short 10 to 20 minute online training. If you go to these that website there, you can get certified. Just take 10 to 20 minute course. You can be certified in it. They will send you the MoCA test, and you can do it yourself at home. So I can't emphasize enough. You'll want to get this tool, and if you're a physician wanting to diagnose it, you want to have this in your office. It's really simple to do. And if you're at home and you want to do it yourself, just go online, get certified. It's really easy. Okay, so once you've done the history and once you've done the MoCA test, you ask, do these fit the picture of Alzheimer's? Notice we say probable Alzheimer's because the definitive way to diagnose Alzheimer's is you've got to do a biopsy of the brain and see the amyloid or tau tangles. And we usually don't do that, okay? Probable Alzheimer's dementia is a syndrome of dementia defined by the following characteristics. You've got interference with ability to function at work or at usual activities, a decline from a previous level of functioning and performance. It's not explained by delirium or major psychiatric disorder like depression. Now, there are some simple depression. There's a 10-question thing that you can do for depression that can also help rule that out. Cognitive impairment should be established by history taking from the patient and a knowledgeable informant. And that question set up, the questions you have there in your sheet can also help with those. And you would also want the objective mental status examination or neuropsychological testing. And again, we recommend the MoCA test. A positive score of 25 out of 30 or less indicates either minor cognitive impairment or dementia. If the patient meets the first criteria, then you can move on to the next step. Now that's a picture of the MoCA test. So, continuing, for Alzheimer's, you need cognitive impairment involving a minimum of 2 of the following domains. There would be impaired ability to acquire new information and remember new information. That's on the MoCA test when they give you those 5 words to remember 10 minutes later. So the MoCA test will give you that information. There should be impaired reasoning and handling of complex tasks, poor judgment, lack of insight. That's not on the MoCA test, but you can ask people, what... Well, I'll give you an example. We had a lady, she brought her mother in and says, I don't think she should be driving. She doesn't have good judgment anymore. She really shouldn't. So I said, well, okay, can you explain this proverb to me? People who live in glass houses shouldn't throw stones. And the idea is that, yeah, if you throw stones at somebody, they're going to throw a stone back. And if you live in a glass house, your glass house is going to get broken. Well, her response is, you shouldn't throw stones. That's not nice. I mean, people shouldn't throw stones. That's just not nice. She didn't understand. She didn't have any concept beyond that. So that's a parable you can ask. When she left, I shared this understanding of proverb with, we have several receptionists, and I shared the proverb, and one of the receptionists said, well, she's right. You shouldn't throw stones. That's not appropriate. And I thought, uh-oh. So anyway, that's a proverb. Impaired visual spatial abilities. On the MoCA test, they have here's the picture. You have them draw a picture of a box. And if they can't do that, then that's qualifying for impaired visual spatial abilities. Also, they do draw a clock. And those are one of the more sensitive findings. They're not able to do that. Impaired language function, trouble finding words, which is a later finding. And there will be changes in personality, behavior, and comportment. The MoCA test will give you the answer to most of these questions. And again, you're going to be amazed that some people who converse normally actually have trouble with the test. If the history points to Alzheimer's dementia, and if the MoCA test is less than 26, you will want to rule out other causes of dementia. As I said, one of the first tests is usually an MRI, a brain imaging test, because, again, you want to rule out other causes of dementia, like multi-infarct dementia that I mentioned earlier the patient had that came to see me about it. Other things that an MRI can show you, which can cause dementia, chronic subdermal hematoma. If there's been a bleed in the brain and the clot is still there, compressing part of the brain, that can cause it. A cerebral neoplasm, brain cancer, normal pressure hydrocephalus. It's increased. That's an increase in volume of the cerebrospinal fluid in the brain. It can cause a dementia. Regional brain atrophy, suggesting frontotemporal dementia. That's another type of dementia. If the temporal lobes on the side are shrunken, which can show up on the MRI, that points in a different direction. In Alzheimer's, the most characteristic finding is reduced hippocampal volume or medial temporal lobe atrophy. This shows up on an MRI, and the MRI, they need to have a program that does volumetrics that can actually determine the volume of the hippocampus. And then that can give you a number that can point you in the direction of Alzheimer's. Now, since hippocampal volume decreases with age, ordinarily, you have to get age-corrected normals of what a normal size is for that particular age. And this contributes to the diagnosis, but again, it's not sufficient to make the diagnosis. Volumetrics can predict the rates of progression of mild cognitive impairment to dementia. However, the tools to generate these measurements are not widely available, nor have these findings been validated in a clinical practice setting. So the MRI really is to rule out other probable causes of dementia. MRI can give you another piece of information. Lecanemab, this is a humanized monoclonal antibody, is directed against soluble and insoluble forms of beta amyloid in the brain. And lecanemab reduces the amyloid beta plaques. It will help dissolve the plaques, the accumulation of which is the defining pathophysiological feature in Alzheimer's disease. Now, that is a new pharmaceutical which is used to try to get rid of the plaque. The FDA has recently approved the use of lecanemab. However, there are possible side effects of this. It can cause vasogenic edema, that's swelling in the brain. It can cause secretions, effusions in the brain. It can cause hemosiderin deposition. These are the pigments from bleeding in the brain. These are microhemorrhagings. And most cases are asymptomatic, but there are serious and fatal symptoms have been reported. A T2 weighted MRI can tell the presence and severity of the microhemorrhaging finding, which if present can exclude the amyloid targeted therapies. So what's happening is, because the FDA has approved this drug, you have to be sure that it is safe to give the drug, and the MRI can help do that. And because of this, it's easier to get them to pay for the scan or insurances. If the MRI does not reveal other causes of dementia, then the next step is the amyloid PET scan. In the amyloid PET scan, they have a ligand which binds to amyloid plaque and is labeled with a radioisotope. So you've got this tracer. It's injected, and it binds to the plaque, and then it emits positrons as it decays. And then a PET scan has a positron camera, and that is used to measure the decay of the tracers in the human tissue, and it shows you areas of increased tracer activity. That's the amyloid PET imaging. A large trial in 2017 showed that the amyloid PET scanning significantly impacted clinical management and etiological diagnosis. The FDA approved lecanemab, and so the Centers for Medicare and Medicaid Services updated their prior restrictions on the coverage so that they are now covered by Medicare and the VA. In other words, before, Medicare was not willing to pay for the amyloid PET scan. Now they are, because you have to have that to make sure the amyloid is there before they use this risky new drug that they have also approved. So this is because if you're going to use amyloid-targeted agent for dementia, you want to be sure amyloid is present and, again, contributing to the dementia. So that's somewhat new. They didn't used to cover amyloid PET scans. The FDA says a negative scan reduces likelihood of a patient with cognitive impairment as having Alzheimer's dementia. A positive scan, however, indicates the patient has amyloid pathology, but may also have other pathology causing impairment. So how do you determine a positive scan? It's currently based on the radiologist's interpretation. The radiologist says, yeah, this looks like positive amyloid PET scan. then that's a positive diagnosis, and then Medicare is going to pay for the drug. However, research is coming up to get more quantitative, objective measures to tell what a positive and negative amyloid PET scan is. The other imaging that can be used to help confirm the diagnosis is a FDG PET scan and a SPECT scan. Now, the way a PET scanner works is you tag sugar with an isotope, something that will release positrons, and that sugar is preferentially taken up in areas of high metabolism, because if the cell's doing work, it's going to suck up the sugar, and then it will light up when you do the PET scan. And it can show areas of decreased metabolism. So if you have decreased metabolism in certain areas of the brain, that's consistent with Alzheimer's. The other hand, SPECT scanner is a gamma-emitting radioisotope, is bound to a ligand, attached to certain tissues in the body, such as thyroid, heart, tumor, and brain. It's taken up by tissues that have a good circulation. So if there's a part of the brain that's not getting good circulation, it will also not take up this SPECT scanner. And so you can say, yeah, this part of the area of the brain is not getting good circulation. That's what the SPECT scan shows. In Alzheimer's dementia, these scans together show areas of low metabolism and low circulation. And these will be in the hippocampus, the precuneus, the lateral parietal cortex, and the posterior temporal cortex. Anyway, there are places that are typical in Alzheimer's dementia that have less metabolic rate and less circulation. There are other tests, but these are usually done for research purposes only. The FDG PET requirements for coverage in the differential diagnosis for Alzheimer's and frontotemporal dementia. People want to know if it is covered by Medicare. We had a friend of mine who's an obstetrician, and his wife was a preventive medicine specialist, and he was applying to get work at one of the hospitals, and the administrators were excited to say, "Oh yeah, we need an obstetrician. We really do." And what did you say your wife did? She says, "Oh, preventive medicine. She helps people get off their medications." I said, "Oh, that's wonderful. We need that too." But then he looked kind of frightened. He says, "Can we bill for that?" That was the issue. So then people want to know if you can bill for it. And basically, an FDG PET scan is considered reasonable and necessary in patients with a recent diagnosis of dementia and documented cognitive decline of at least 6 months who meet diagnostic criteria for Alzheimer's dementia and frontotemporal dementia. If you can't tell those apart, then you can do this scanner. These patients have been evaluated for specific alternate neurodegenerative diseases and other causative factors, but the cause of the clinical symptoms remain uncertain. So there's certain requirements for Medicare to pay for that. Is it frontotemporal dementia? That's one of the questions that you have to ask if they have dementia. About half of this frontotemporal dementia are a behavioral variant. It's manifested by disinhibition. They may walk out somewhere naked. Apathy, loss of empathy. They can't bond with you emotionally. Hyperorality. They may be eating obsessively. Compulsive behavior. Things to ask about the patient to see if they have that kind of dementia. Has the patient said or done anything in public that has embarrassed others? Does the patient appear to have lack of disgust? Does the patient seem indifferent or oblivious to others' feelings and less warm or affectionate, especially toward grandchildren and pets? Have food preferences changed or table manners declined? Does the patient seem more concerned with timekeeping or tend to watch the clock? Has there been a change in the patient's sense of humor? Has the patient developed new hobbies or interests pursued obsessively, especially with a religious or spiritual bent? Okay, well, aside from PET imaging, the amyloid PET scan, there's also tau PET imaging. They've developed tracers that'll attach to the tau tangles, which are also present in Alzheimer's. Numerous studies have demonstrated that these tracers better track disease progression and more highly associate with patterns of atrophy and clinical features than amyloid PET does. But the FDA-approved tracer, it's a fluor tau psi PIR F18, can determine the neurofibrillary tau burden, but cannot measure non-Alzheimer dementia tau in frontotemporal lobe degeneration. So there's a limited insurance coverage for that, and that's really not something you'd be too interested in. However, biomarkers are something that are very helpful. The original biomarkers were from spinal fluid, which you got a spinal tap from. And if you had a low CSF amyloid beta 42 or a low CSF amyloid beta 42 to amyloid beta 40, or a low amyloid beta 42 to phospho-tau, that was indicative of Alzheimer's. A positive amyloid PET imaging, of course, was another imaging way of looking for Alzheimer's. If the CSF had increased total tau or increased phospho-tau, that was indicative of Alzheimer's. And tau PET imaging that used a tracer was also helpful. The problem is, of course, these biomarkers add confidence to the diagnosis of Alzheimer's. They can also help rule out Alzheimer's dementia. Importantly, evidence of the presence of amyloid is essential for initiation of disease-modifying amyloid-targeted therapies that are just coming out. Topographic biomarkers, like the PET scans, are less specific than molecular biomarkers, but correlate better with clinical symptoms. None of these tests is valid as a standalone diagnostic test by itself, so you have to correlate it clinically with their history, with the imaging, and with the biomarkers. Medicare coverage for CSF amyloid beta testing is usually only considered when evaluating eligibility for certain FDA-approved Alzheimer's medications, not for routine diagnosis. However, there is discomfort and with the spinal tap. And the more limited access to PET scanners, plasma biomarkers are an attractive alternative. That means instead of doing a spinal tap, we draw your blood and we test your plasma blood biomarker. And that shows considerable promise, but they have not yet have an established role in clinical practice. More studies were needed. Nonetheless, commercial versions of these measures are starting to be used. You can measure phospho-tau 181 and phospho-tau 217, and they demonstrated association with the amyloid and tau PET imaging. So they're looking at, drawing the blood and doing these blood tests is a lot cheaper than a PET scan, and it correlates very closely with what the PET scan is going to show you anyway. Here's a meta-analysis of studies up to May 2021. The p-tau 181 ratios of Alzheimer's dementia compared with the cognitively unimpaired was about 2 to 1. In other words, you would have twice as much of this tau in someone with Alzheimer's dementia as someone who was normal cognitively. A p-tau of of mild cognitive impairment compared to cognitively unimpaired was 1.34. So again, you had higher p-tau 217, and in this one it was p-tau 181 in patients with mild cognitive impairment. So it can actually, it's sensitive enough to where it can give you a hint if their mild cognitive impairment is from Alzheimer's dementia, or if it's even higher, that would be Alzheimer's dementia. Here, the ratio of p-tau 217 are given. It's the ratio of Alzheimer's dementia to an unimpaired person was 1.89, and mild cognitive impairment was about 4. These are the plasma markers that are available through LabCorp. $125 for each one, total of $250. Now, this is the professional co-op prices. These are the discounted prices that physicians can get. I'm not sure what they would charge you if you went in yourself. But I have to agree personally. I think if I had my choice between a spinal tap and a blood draw, I think I would pay the $250 out of pocket and get the blood draw. Okay, this is retinal scanning. I just want to bring this up. In 1906, Alois Alzheimer identified brain plaques and tangles in Alzheimer's dementia patients. These were autopsies. He found the plaques in the brain. In 1985, the amyloid plaques were purified from Alzheimer's dementia brains at autopsy. At autopsy, however, it's a little too late to do anything for the patient. Wouldn't it be nice if we could visualize the brain to identify these amyloid plaques while the patient was still living? And it turns out that the retina shares a common embryonic origin as the brain and is its direct anatomic extension. Excuse me here. Unlike the brain, which is shielded by an opaque skull, the retina is optically accessible space that can be directly visualized non-invasively at the vascular, cellular, and molecular levels with high resolution. This offers an affordable means to monitor CNS abnormalities in the clinical settings. But is the retina affected with amyloid plaque the same way the brain is? We want to find out. To find out, in 2010, autopsy studies of the retina in those with normal cognition and those with Alzheimer's dementia were done. This is how they did it. And this allowed them to see how retinal samples, well, this on the left, that's how they got the samples. And this allowed them to visualize the surface of the retina as well as sections going through the retina. On the left is a microscopy of a normal retina, someone with normal cognition. There's minimal, if any, staining of the amyloid plaque. But in the middle is an Alzheimer's dementia retinal plate showing very heavy staining of the plaque. On the right is higher magnification of Alzheimer's dementia plate showing very heavy staining. But does this amount of plaque in the retina truly represent the amount of plaque in the brain? Well, to find out, they did autopsy studies on those with varying amounts of amyloid beta plaque. The vertical axis shows the amount of brain plaque. The horizontal axis shows the amount of retinal plaque in various subjects. And as you can see, the more brain plaque, the more retinal plaque. Thus, the retinal plaque actually does give a good picture of what the plaque is in the brain. The problem with these studies, of course, is that they can only be done when the patient has died. Is there a way to visualize the retinal plaque while the patient is still living? Are there ways to visualize it with an ophthalmoscope instead of a microscope? So they needed a dye to stain a living retina with. Now, they knew they could use fluorescent dyes attached to antibodies directed against beta amyloid plaque. And on the upper right is an Alzheimer's dementia brain stained with this fluorescent antibody to the plaque. However, they wanted something they could use safely in a living person that had high affinity and specificity to amyloid plaque, and that had also had autofluorescence. Now, autofluorescence means it will glow when you shine a certain frequency of light on it. They also wanted something that was cheap. So they thought curcumin would fit the bill. It's an herbal food supplement that you can get at a health food store. Curcumin has a high affinity and specificity to amyloid plaque. It also has autofluorescence. It will glow when exposed to the correct wavelength of light. So the first question is, does curcumin give the same picture as fluorescent antibody does? The upper right is an Alzheimer brain stained with the amyloid beta antibody, which appears red. In the lower right is the same section visualized to show the curcumin stain in green. And they both identified the plaque in the same way, indicating that, yeah, the curcumin appears to work just as well as the antibody, the amyloid beta antibody. So, can this fluorescent testing be used to differentiate normal cognition retinas from Alzheimer's dementia retinas? Here are flat plates using the fluorescent stains. Now, these are on autopsy. The left in the big box is a normal cognition, and no plaque seen. Underneath is the same visualization with the fluorescent amyloid beta in orange and the left curcumin in green. Then in the middle, you have Alzheimer's dementia, and that's the retinal plate showing areas of amyloid beta plaque stained with the curcumin. And underneath is the same view, visualizing it with amyloid beta antibody versus the curcumin. And again, you get the same pictures. Can we see early plaque in mild cognitive impairment? And yes, the flat plate on the left is again mild cognitive impairment with fewer amyloid beta plaques compared with the Alzheimer dementia plaque on the right, which showed abundant plaque. So you see on the left, just a few plaques, and on the right, a lot of plaques. And so as Alzheimer's progressed, the number of plaques in the retina increased. But these are, again, pathological studies. Can we do it in a living patient and see these plaques in a living eye? And so they wanted to stain it with curcumin, so they went to the health food store and they bought Long Vita brand curcumin, and they took patients and they did neuropsychiatric evaluation first, then they did brain imaging with MRI, and then on day 1, day 2, day 3, they fed them the curcumin. And then on day 4, they did retinal imaging of the retina. And this is what they saw. This is with an Alzheimer's dementia patient. All those yellow spots are the amyloid plaque showing up on the retinal scan. These are curcumin bound to the amyloid deposits. Here are 2 images. The one on the left is Alzheimer's dementia. The one on the right is mild cognitive impairment. And as you see, there's a marked difference between the 2 pictures. Much less plaque in the mild cognitive impairment. But they want to get a number on the, they need a number for how much plaque is actually there. And so what they do is they count up the number of plaques found in a pre-selected area. The PMP area is the area they typically select, and they count up the number of plaques, and then they have a more objective measure of the amount of plaque. And using those numbers, they did find that, yes, there was, for instance, if they had a high MoCA score here on the 26, in the green, they had less amyloid plaque. If they had a score on the MoCA test less than 26, indicating early dementia, they had higher amyloid plaque number. However, notice there is a lot of overlap, which makes it difficult. Yes, you had a question? Yeah. Yeah, that's a good question. Um, yeah, I don't know. That's a good question. Yeah, it's a good question. And yeah, I guess you'd have to research, see if anybody's done anything on it. But I kind of doubt it because, again, there's no return on your investment to do the study. There is a possibility of using curcumin with ultrasound. They are doing that with cancers. Curcumin can bind to cancers, and when they do ultrasound, it vibrates the curcumin, and that destroys cancer cells. They've done that with rats. And I don't know that they've done it with Alzheimer's. Yeah, good question. Also, retinal imaging. Okay, well, so it shows promise. Also, Alzheimer's dementia also causes increased vessel tortuosity. You know, the blood vessels are turning more rapidly. And so they come up with a venous vessel tortuosity index, can be calculated. And using these two scores together, they get a PMP amyloid count and the venous tortuosity. When you put them together, there's an inverse relationship between these two scores and verbal memory. In other words, the the higher the score of tortuosity and amyloid plaque, the less verbal memory they have and the less cognition they have. There's a general tendency. Researchers concluded, while non-invasive ophthalmic imaging is expected to be safe and useful for future Alzheimer's detection and monitoring in clinical settings, especially in low and middle income countries, this research is still in its early development stage. There are some limitations and discrepancies of results from different retinal imaging modalities that necessitate additional replication, rigorous testing, and validation against the gold standard neuropathological examination. Hence, studies involving larger cohorts of confirmed Alzheimer's dementia patients will potentially allow transition from biomarker discovery phase to biomarker validation phase, with the prospect of achieving higher sensitivity and accuracy. I called my friend ophthalmologist who worked with us in Guam, Dr. Whiting. He's up in Maine, and he said, yeah, it looks promising, but they're not sending me any patients to do retinal scanning yet. So it's not quite there yet. So once you have a history, and a MOCA test, an MRI, and an amyloid PET supporting the labs, you can diagnose probable Alzheimer's. Again, probable because the definitive way is brain biopsy. And again, these are criteria for diagnosing probable Alzheimer's dementia, and that should be in a handout. Once you've diagnosed probable Alzheimer's, you want to find out what's causing it, because you want to target your therapy to the cause. And those are 4 possible causes. Since his first book, they've come up with other causes. So the list is starting to get a little bit longer. But to try to diagnose these causes, the spreadsheet you've got, it's a numbers or an Excel spreadsheet. It's in your handout. It gives you a list of tests, what the normal value should be, and if the test is abnormal, gives you a page in Bredeson's book that can do some more explanations, and it also gives you some of the therapies that you can do to address the different out of norm values. So remember Eleanor, declined into Alzheimer's. We talked about it earlier. What happened to her, within 6 months, she noticed clear improvements in her cognition. She underwent neuropsychological testing after 9 months, which confirmed the improvement. Her feeling that she was back to normal was no figment of her imagination or wishful thinking. It was real, quantified by the neuropsychological testing, and was objectively measured. What did she notice? She said, facial blindness. I'm now significantly better at recognizing people and remembering that I had met them. I noticed this in September when I attended the Parents' Day at my kids' school. Usually that day makes me very anxious because I don't remember who I know, whom I've met, and am not sure who people are without their name tags. This year I recognized all sorts of people, remember their names and their kids' names, and knew little things about them. Even more, I had confidence to say their names because I knew them. 4 o'clock fatigue, that has gone away. I now see that my father experienced this exact change in his late 40s. He cut his days shorter at the hospital where he worked and zoned out with TV after 3 p.m. every day at home. We thought he was just exhausted from work. Now I know it was early dementia. You can't see this when you are in it. Reading comprehension and recollection improved. Now when I read something, someone tells me something, I remember a lot of it, a big change for me. Now I can engage in conversations that are not in my field. Vocabulary and word search. I'm now using more words to describe things. I hadn't realized that my vocabulary had become limited and my speech less sophisticated, but it had. I see this now, and I'm starting to use big words again. I still search for words, but much less often, and now I actually find them. Clarity and thinking speed. I'm significantly sharper when helping my kids in essays and homework. I wrote one piece recently, something I haven't done in years, and speed and focus, that's similarly to when I was younger. Typing speed is back again. And big thing, driving, the anxiety which I had about driving is starting to let up because she's processing things faster. Appointments and to-do lists. I can recall appointments better now, and the stress from the constant fear of missing things is abating. It's not perfect, but definitely improved. It takes much less effort to remember something. I no longer ask my kids to leave written messages whenever they ask me to do something for them. Sleep. I did notice an improvement in my sleep when I started taking melatonin and magnesium in the evenings at the outset of the protocol. I found that my first sleep stretch felt deeper and lasted for 3 to 4 hours longer than it had, and that on some nights my awakenings didn't last as long or happen as often. And I don't feel tired all the time anymore. And when I've had a decent sleep, I feel great. Caffeine. When I drink coffee, I feel an alertness I had stopped feeling. And again, don't recommend caffeine as a regular drink. Foreign languages. Surprisingly, the Chinese and Russian that I had not used in years started coming back. It came streaming back, and at one point I started writing down each word that reappeared. One of the things that strikes me most about all of this is that I couldn't have told anyone about all these things and that they were problems last year. I couldn't put it all together. I was functioning on the outside. I just thought things were sort of fuzzy, and I couldn't specify the problems. The changes come on slowly so that you don't really notice them. The mental fatigue is so powerful that it makes you think you're just exhausted. Now that I am improving, I can see the deficits for what they were. I feel like it was an awakening. Just hope it lasts. And she wrote and thanked Bredesen for the way his protocol has truly changed her life. So that's an introduction of what does Alzheimer's look like and what are some of the tests you can do. Dr. Youngberg's talk also gave you some options where they can get these blood tests done for you and give you a score, and that would be one step beyond where we are.